Hello, everybody. Welcome again to our webinar by SSPD. This activity is being accredited by 2 hours by Saudi Commission for Health Specialty. It is my pleasure to moderate this scientific session. I am Dr. Mohammed El Patal, is a board member of SSPD and Pediatric Dentistry consultant and associate professor at Al-Azhar University and Prince Sultan University. Today we have 2 distinguished speakers. The first speaker will be Dr. Iyad Hussein, is a consultant in pediatric dentistry and assistant professor at Mohammed bin Rashid University, Dubai, in United Arab Emirates. Dr. Iyad joined an international team to training the next generation of United Arab Emirates postgraduate in pediatric dentistry. It is fully registered in United Kingdom and has experience more than 30 years. Dr. Iyad received his pediatric dentistry training at Leeds Dental Institute, England. Dr. Iyad have 35 scientific publications in British and international high-impact dental journals related to pediatric dentistry and oral surgery and behavior science. Dr. Iyad is also a review of many international journals, such as International Journal of Pediatric Dentistry, Dental Stomatology, British Dental Journal. Today will be discussed about whole technique, the revolution in pediatric dentistry. Now I would like to welcome Dr. Iyad and to share your screen. Welcome, Dr. Iyad.
Thank you very much, Prof. Mohammed. Ladies and gentlemen, 1 second, please, while I share my screen.
Yes, welcome.
Now, let me just see here what. Can you see my screen just right now?
Yes, clear.
Okay. Assalamu alaikum. Good evening, ladies and gentlemen. It gives me great pleasure to present to the Saudi Society of Pediatric Dentistry scientific session for this evening. I would like to thank Dr. Manal Al-Malik for her kind invitation, and I would like to also thank my colleague Dr. Hala bin Laden for suggesting my name in the first place. Thank you, Prof. Mohammed, for that introduction. The title of my topic is The Whole Technique, a Global Perspective of a Revolution in Pediatric Dentistry. I would like to extend to you very warm greetings from my university here in Dubai, Mohammed bin Rashid University, or MBRU. It's a beautiful university and it's a new kid around the block. And as you know, Dubai is a modern city in a buzzing hub of tourism and finances in the Middle East and North Africa region. On that note, I would like to kind of disclose no financial interest at all. This presentation is purely scientific. Let me start with a prelude with some clinical context. The place is Dubai Dental Hospital, which is part of MBRU and Hamdan bin Mohammed College of Dental Medicine, where I work and have been working since 2014. And the date is 2016. It's just a normal, average, sunny day here in Dubai, and a 5-year-old boy shows up who is referred to me from an experienced general dental practitioner colleague. Here he is. He has asymptomatic caries affecting all his E's and 3 of his D's, and he has loose upper A's as well. His father is a severe dental phobic. He was actually sweating and profusely anxious and clearly unsettled in the surgery. And this was reflecting upon his son as well. So as pediatric dental surgeons, what can we do and what can we offer him? Let's have a close-up look at these bite wing radiographs, and you can see that 7 out of 8 of his primary teeth have dental caries, except the upper right D here. The rest have dental caries. So this child successfully underwent dental treatment by an enthusiastic MBIU postgraduate, Dr. Amal Al-Mahmoud, who's now a specialist in Abu Dhabi. She did not involve any surgical excision of the infected enamel nor the dentine. And she didn't even use any needles nor drills. And this was a very successful outcome. Clinically, this patient was treated with the whole technique. There was 0 drills, 0 injections, 7 stainless steel crowns, plus a good prevention plan, and 1 happy child and 2 ecstatic parents as well. That's the kind of clinical picture here after the completion of treatment. You see the stainless steel crowns in place, the sealants on the 6s. The upper A's, we left them to exfoliate naturally. Well, we follow up these patients periodically, clinically and radiographically. Here are the baseline bite wing radiographs. 6 months later, you can see the stainless steel crowns, the 7 stainless steel crowns in place, and no evidence of furcal pathology. 12 months later, similar picture, and the 6s now erupting. 3 years later, as you can see here, the teeth, the 6s have erupted fully. There's no caries on the mesial of the 6s. That upper right D remained caries free, and the stainless crowns are in situ, and there's no furcal pathology as well. Now, a year later, so 4 years after kind of treatment, when he was 9 years old, he comes back and shows up with some discomfort on the top left-hand side. We put our hands on our heart, thinking, oh goodness, what has happened? It turns out that this patient was having an exfoliating 6-4, and it was slightly loose, causing some discomfort. And the 2-4 was erupting, and we left that to Mother Nature for it to fall out on its own and let the permanent tooth erupt. The problem with this child when he came in, that he had non-pulpally involved asymptomatic carious primary molars, and he was treated with the whole technique. I'll be talking about that a little bit. And the whole technique is one method out of many for dealing with the carious primary molar. I will pepper my presentation with some of the Dubai experience about the whole technique. Now, the title of my topic includes global, the word global, and you cannot but talk about the global pandemic. I hope you and your loved ones are all staying safe and well. This COVID crisis has no doubt affected pediatric dentistry, as we as a profession have been associated with the king of aerosol generated procedures, AGPs, namely the pneumatic drill. In 2020, our dental profession had an upheaval with calls to spare patients and dentists the drill and the use of the drill and adopt minimally invasive dentistry wherever possible. Because of the risk of transmission of SARS coronavirus 2. The first call was actually published in the International Journal of Pediatric Dentistry early in the corona crisis by Malinini et al. And this message was clear. Use minimally invasive procedures that minimize the elimination of aerosol generation. Now, this important message was reiterated in a highly quoted critical view of the most up-to-date global pediatric dentistry guidelines related to COVID. This was published in the European Archives of Pediatric Dentistry, proudly by our MBIU group, led by my friend and colleague, Dr. Manal Halabi. When I say highly cited, it's been out for quite a short while. It's been heavily cited by groups like the Center of Disease Control in the United States. In essence, this paper emphasized on the need to reduce AGPs and adopt biological dentistry and minimally intervention dentistry, such as the silver diamine fluoride, ART, and the whole technique as well. And I would recommend looking at these guidelines if you haven't them already. But even before all that, the UK Leeds Sheffield group, led by my colleague and friend Ala Benihani, published several papers in 2017, 2018, so before the COVID crisis. They reported that the outcomes from conventional and biological treatment of caries of the primary teeth were the same. And the patient acceptance of both methods were the same as well. This is in a retrospective study of 800 plus teeth. And the cost was lower with the biological approach as well. So it made sense to adopt using or incorporate the biological approach for managing dental caries in practice. And the question is, are you a drill and fill dentist only, or have you adapted biological dentistry into your practice, and are you practicing biological dentistry? The call for avoidance of the drill is not new. The whole technique is not new. Take this piece of news from the BBC website, published in 2001, so almost 20 years ago. And it was calling to spare children the use of the drill, the dreaded drill, and at the same time announcing to the world the birth of the whole technique. And in the picture is Professor David Evans from Dundee, and he, in the year before that, in the year 2000, stood up in front of the British Society of Pediatric Dentistry, and I was in the audience at the time, and he started talking about the whole technique to a very shocked audience, and we were completely in shock and disarray about what this is all about. But why are we actually calling for no drills and no injections? Well, it's because of the real phenomena of dental anxiety, a problem that can go into adulthood and may often necessitate the involvement of a clinical psychologist to unravel the deep-seated dental anxiety, like this kind of method for managing adult needle phobia. I happen to work with a clinical psychologist for adults, and it made me realize the impact of giving local anesthesia and drilling and filling in children, particularly, and how it impacted the adults later on in life. But it is a community problem, it's not an individual problem. The UK Adult Dental Health Survey in 2009 highlighted about 36% of the population in the UK were dental phobic, with 12% of them being severely dental phobic. About a third of the adults said that having a tooth drilled will make them very or extremely anxious, while roughly a third reported similar levels of anxiety when local anesthesia was used. And that's not just in the UK. In the US, the American Dental Association published a document about why adults forego dental care, and they reported about 70% of Americans were actually extremely anxious, and they actually avoid dental treatment altogether. Now, 70% may not sound like a big percentage, but that's about 30 to 40 million people. Well, what about children? Well, there are lots of research about anxiety in children, and this is our own piece of research conducted here in Dubai and led by my colleague and friend, Dr. Safia Al-Gharibi. She kind of surveyed children and adults in the UAE, and we found out that severe dental anxiety was prevalent in this sample, about 22% if you ask the children, 33% if you ask the parents. And the cause of anxiety was extractions, injections, and fillings, i.e. drills. So this is a real problem. Dental anxiety exists. But we cannot give up the drill or local anesthesia entirely, nor am I suggesting that at all. When caries affect the pulp, we have to adopt invasive means, local anesthesia, rubber dam, caries removal with the drill, and it could be conservative, such as the very successful indirect pulp cap, which is about 93–94% successful according to Marchi et al. In 2006, or even consider pulp therapy. We are pediatric dentists and we have the skills to do so. When the pulp is involved, some patients don't want stainless steel crowns and they prefer to have composite restorations, then we can provide that type of restoration. But when the pulp is involved, obviously pulpotomies, pulp therapy, stainless steel crowns using the conventional method approach under rubber dam quadrant dentistry applies, and that is a cornerstone of our management. So it's still a big bulk of our work as well. But I mean, preparing a tooth, fitting the crown is straightforward in our hands, and this could be easily done also under general anesthesia as well, where we know that the quality of life of children receiving restorative care, complete oral rehabilitation under general anesthesia improves the quality of life of children, according to this publication here, which is just recently out in the BDJ and led by my colleague, Dr. Khaloud Al-Antali. The quality of life can improve with conventional restorative care, so no doubt about that. But there are two schools of thought now in the management of carers of the primary teeth, the biological approach and the conventional approach. And they can run in parallel in your clinic, or even in one patient's mouth, you can adopt conventional versus biological, so you can mix and match. Here's the two patients that I treated that reflected the changes in philosophy over the years, and they were treated about almost 20 years apart, one in Leeds and one in Dundee in Scotland, home of the Hall technique. So here we are, Sarah on the left. Here she presented with lots of carers in the primary teeth, and Henrietta on the right, again, similar picture of carers as well. And they both ended up with having one tooth extracted, so local anesthesia was used. But they had restorative care, and they both received 7 stainless steel crowns fitted on their primary molars. So Sarah on the left had about 7 or 8 injections over the period of quadrant dentistry appointments that she had, while Henrietta on the right received no local anesthesia whatsoever and had 7 stainless steel crowns. Now, both were happy in the end. I noticed Sarah in the end was bringing her teddy, as you can see in the picture there, in the latter appointments, because she was needing a bit of emotional support. So maybe she was feeling the pressure of local anesthesia and the drill, and it was a bit too much for her, because she had pulpotomies and stainless steel crowns conducted, as you can see from the images above there, while Henrietta had stainless steel crowns using the Hall technique. Conventional work is hard work for children. It may be easy for us, but it is hard work for children, and we have the skills to make it as easy as possible. But the more, I mean, I've been working in this field now for 30 years, and I notice it's becoming even hard work for me. But as I kind of get older and learn more, I've learned a lot about the dentinal pulpal complex, and realize how resilient that dentinal pulpal complex is. And given the chance, it can survive the onslaught of caries, like this image that you can see there in the circle. This pulp is still vital despite the big cavity there. So we tend to underestimate the dentinal pulpal complex. But the problem that I'm addressing here is this. It's the non-pulpally involved asymptomatic caries primary molar. Okay, so that's the problem. And that, and particularly in primary teeth that are not exfoliating. So it's enamel caries E1 or E2, or dentinal caries D1, D2, but not D3, as you can see from the image here. And some of these caries lesions are not visible, so we have to go and search for them. So we have to search for the non-pulpally involved asymptomatic caries primary molar. And this relies on a good dental pain history and a recent set of bite wings. What I say recent and decent. This set of bite wings that you can see on the screen right in front of you was just taken last week. And it shows asymptomatic caries primary molars, all 8 of them, okay, different stages of development. So when a child comes in, when there's from the age of 3, if there's any tight contact, obtain decent quality bite wings, but decent and recent. This child is considered a high caries risk, and he has 8 caries primary molars. He's a prime candidate for the Hall technique. But what is the Hall technique? I mean, many of you already know about this, and many practice it already. Some of you may have not been practicing or have heard about it, but not sure. The Hall technique, in my view, is the vanguard of the biological approach. It is a method for managing the caries primary molar without local anesthesia, without any drilling, without caries removal, without crown reduction. And there's a decent free manual for the Hall technique available. If you just Google Wikipedia Hall technique, and it will show up. And this is published by the Dundee group, Dr. Evans, who you saw in the BBC picture, and Dr. Innes. The whole technique has been incorporated into the AAPD guidelines, not endorsed, but been mentioned in the AAPD Pediatric Restorative Dentistry guidelines. What are the ingredients for the whole technique? Well, you need a child, obviously, with caries prime molars, in early enamel or early dentinal caries, one surface or multi-surface, but no clinical or radiographic signs or symptoms of pulpal pathosis. So no evidence of irreversible pulpitis or interradicular pathology. And you need to get a decent recent set of bite wings to show these, like what you see on the screen here. And there should be at least 1 millimeter of a radiopaque band between the pulp and the caries lesion on the bite wing. So recent and decent bite wings. Don't rely on old bite wings. If you have them taken a year ago, you can't start the whole technique relying on old bite wings. What are the steps of the whole technique? This is an all-whole case published by one of my colleagues, my colleague Dr. Patal Reith, who was the first graduate of MBIU University, and we identified a non-pulpal involved asymptomatic caries primary molar clinically and radiographically, like you see here. And then if the contacts are tight, you place 2 elastomeric orthodontic separators in, or 1 according to the tooth, and 2 or 3 days later, maybe a day later, maybe a week later, depending on the circumstances. Even there's evidence to suggest that even half an hour of fitting an elastomeric orthodontic separator would create enough space to allow the crown to fit in. Then you go to your stainless steel crown box, you pick up a stainless steel crown that fits the tooth and just bounces gently onto the contact point, but you don't press it right through when you're trying it out. Then you fill the stainless steel crown with glass ionomer or cement, and then get to digitally compress the crown on, ask the child to bite afterwards, and the patient will actually bite on the crown to get it into position. Notice that the bite is slightly open by maybe 1 millimeter. We'll come to that later on. So as I mentioned to you, that was an all-whole case that we reported there. An all-whole, in the terminology we use is for 8 stainless steel crowns being treated using the whole technique. So here are the pre-operative radiographs, the bite wings, recent and decent bite wings, showing the furcation areas, showing that the pulp is 1 millimeter at least away from the caries lesions. 1 year follow-up, the stainless steel crowns are in situ. 2-year follow-up, the stainless steel crowns are in situ, no focal pathology, the 6s are starting to erupt. 3-year follow-up, the 6s have erupted and no focal pathology again. 4-year follow-up, what's happening? The permanent teeth now are coming through and they're just causing the exfoliation of the primary teeth and they're falling out as normal teeth. So we're almost creating a category of patients who've had restorative treatment but haven't had a single injection nor a drill at all. And the idea behind this was Dr. Norna Hall, who brought this technique to the forefront of pediatric dentistry. 1 or 2 tips to mention here that you can treat stainless steel crowns on the E's and D's. You should start with the deepest cavity. E's are usually easier than D's, so I say E's stands for easy and D's are difficult, especially the upper D's. And you can treat 2 stainless steel crowns at the same time, but never start with 2 in the first visit. If you can avoid it, it's best. You can place 2 diagonal ones, so diagonally, or you can place 2 contralateral ones, so on either side of the arch, but never adjacent and never opposing in 1 visit. Now, the whole technique was named after Dr. Norna Hall, who was a dentist in Scotland. In the UK, children are treated for free, and dentists claim money from the government for the work they have done. Stainless steel crowns were not used by general dental practitioners that much. So when Dr. Norna Hall started claiming more money for the stainless steel crowns that she was doing, because she was thinking completely different from the rest, the government was thinking, hold on, what are you doing here? Let's see your work and let's audit your work. So she presented 2-year audit results, and they found out that the success of her method, and this is late 80s, early 90s, was about 88%. So Dr. Evans, the BBC guy I showed you, and Dr. Innes took this opportunity to study this further and produced in 2007 a randomized controlled trial of the whole technique. It was a split mouth design, 132 children, 8 were lost for follow-up, so we had 124 teeth, split mouth design, and it was done by general dental practitioners. It was published in the BMC Oral Health. This is the pivotal whole technique study. So they had the split mouth design, 2 matched lesions, let's say lower left E, lower right E, as you can see in the image here. One was treated with the whole technique and the other one was treated randomly with a restoration of the GDP's choice, like composites or glass ionomers. They followed them up for up to 2 years and looked at outcomes that were clinical and radiographic: success, minor failure, major failure, and they also looked at patient and carer and dentist acceptability of either method. So, for instance, if you see here in the image, a minor failure would have been a lost restoration that can be re-restored. A major failure would have been a sinus developing on the tooth. Secondary carers around the whole technique without any symptoms would have been a minor failure. An abscess developing around the whole technique crown would have been a major failure. So they looked at them over two years, and guess what? Well, there were major failures for about 2% in the whole technique and minor failures about 5%. So the total failures were about 7%. Success rate was about 93%. While there was some pain in patients who received the whole technique, about 2%, while the controls failed miserably here. Now, the very high failure rate in these controls beg the question, were they actually done appropriately? Well, they were done in the general dental practitioner environment where most of the carers is dealt with anyway. Preference for the whole technique according to the dentist and parent and carer and the child favored the whole technique. See these red bars here? The dentist preferred the whole technique, the parent and carer preferred the whole technique, and the child preferred the whole technique compared to the conventional method. So they concluded that after 2 years, the whole PMC, the preformed metal crown, showed more favorable outcomes for pulpal health and restoration longevity than the conventional restorations used here. Again, this is done in the general dental practitioner environment, so the conventional restorations maybe were not specialist standards. They followed these patients up for 5 years and again found that the whole technique had lower minor and major failures compared to the conventional restorations. Now, this point was picked on in a critique of this study by Nanar et al. In 2012 in the US, and said, well, okay, the whole technique was successful, great, but the controlled restorations were not specialist level standard. And because some of them were composites, the majority of them were glass ionomers in class 2s, and glass ionomers in class 2s fail miserably. We know that. There's evidence to support that. But the whole technique success didn't prevent it from actually subsiding into the history books. It actually took on. And in 2017, the British Dental Journal celebrated 10 years of the success of the whole technique. And these are 2 pivotal articles, Innes et al. And Welbury et al. That answer all the questions about the whole technique. But again, it was down to Dr. Nicola Innes and Dr. Evans, who you can see in the photo there, to get this off the ground. And then the global evidence started mounting up with success rates of 92 to 97%. After the British study there in 2007, came out the American study in 2014 by Ludwig et al. And then the German study, a randomized controlled trial comparing conventional restorative care to whole technique, showed high success rates. In New Zealand, on the other side of the globe, high success rates in a clinical randomized controlled trial for 2 years. Another randomized controlled trial was done in Sudan in cooperation with the UK, and over 2 years, the success rate of the whole crown versus the conventional placed crown without pulpotomy, so conventional preparation of the crown, was extremely successful, 93%, 94%. We conducted the study here in the UAE, the bottom one there, and it was a retrospective study conducted by my colleague and friend, Dr. Hala bin Laden, and she found over 2 years that the whole technique versus the conventional preparation technique was actually very, very similar success rates, above 92%. So if I look at the El Amin Sudan study in 2009, the whole technique was equal to the conventional preparation technique of the stainless steel crown over a period of 30 months. And we're talking about 94% success rate. While our UAE study compared retrospectively the stainless steel crowns placed using the conventional prep with no pulpotomy, obviously, as you can see in the radiographs here, with a whole technique crown over a period of 2 years. And we found whole technique was about 97% successful, while the conventional preparation prep drill local anesthesia was 94%. Remember, one involves no drilling local anesthesia, either whole technique, and the other involves drilling and local anesthesia, etc. So you may ask, what about the occlusion? Because that is always the first question. What about the occlusion? Well, look at this case here. This was a patient treated by my friend and colleague, Dr. Iyad Hussein, and she placed here 6 stainless steel crowns, whole technique, and 1 received a pulpotomy and stainless steel crown under inhalation sedation. If I look at that image there after the treatment, this is 6 months after the treatment, I can't say with my hand on my heart that there's any occlusal issues at all. So clinically, we know that there's some dental alveolar compensation that takes place and the occlusion corrects itself within 4 weeks. This has been proven time and time again. The occlusion settles down within 4 weeks maximum. And when I was in Dundee, we published this kind of project here. We looked at the occlusion by methods of 3D imaging of the models taken for patients. So we looked at 10 patients, we took impressions before and after the whole crown, and then 6 weeks later, and then 6 months later. And we assessed these models using 3D laser scanning and caliber measurements and clinical photographs. And we found that the occlusion does settle within 4 weeks. And the dental alveolar compensation that occurs is mainly due to, if you look at this image here, the green image here, to the intrusion of the treated tooth. Now, the intrusion of that treated tooth is where the dental alveolar compensation occurs. The occlusion is just not about teeth. Remember, the occlusal apparatus is a triad of teeth, muscles, and the TM joint. So is there evidence that they're okay with the whole technique? In 2020, 3 papers came out answering this question, and they're all published in the International Journal of Pediatric Dentistry. They looked at the occlusion in India following the whole technique, and they actually did a digital occlusal analysis and the vertical dimension assessment and assessment of the maximum intercuspal position after the whole technique, and they found that it recovers within a month. We conducted a study here in UAE looking at the masseter muscle activity, and we found that actually the masseter muscle activity returns within 6 weeks. In Turkey, they actually assessed the TM joint with the patients who received the whole technique and found that the patients reported no TM joint problems whatsoever. Our study, which was published last January, so a year ago, was conducted by my friend and colleague, Dr. Sally AbuShanan, and she looked at 12 patients who received 1 single whole crown, and she measured their masseter muscle activity by means of surface electromyography. So she stuck these electrodes, as you can see the pictures on the patient's jaws, and we asked them to clench and rest before the whole crown, immediately after the whole crown, 2 weeks later after the whole crown, and 6 weeks later. And guess what we found? We found that, if you see this image on the left here, we found that the masseter muscle activity before the pre-hole was at this level, at clenching, but the ability of the child to clench dropped significantly so immediately after the whole crown. 2 weeks later, that recovered to pre-hole levels. And interestingly, 6 weeks later, we found out that the patient was able to bite even harder with their masseter muscles. We don't know why, but maybe that they're not feeling any discomfort anymore. Maybe their teeth feel stronger. We're not sure why. Now, the rest masseter muscle activity remained the same immediately post-hole, 2 weeks and 6 weeks later. We use that as a control there. So the masseter muscles are not affected. We actually looked at the effect of the whole technique on our practice, and we found it was reducing our need for general anesthesia in many cases if we combine the whole technique with other biological restorative methods, such as the interim therapeutic restorations. And in this paper published 2 years ago and led by my colleague, Dr. Manal Al-Halabi, highlighted this, that the use of the interim therapeutic restorations aids pulpal diagnosis and actually can be combined with the whole technique. It's a GIC, sealing a carious lesion. Look at this case here, which is in the paper. Look at this lower right E here. This E was asymptomatic, but had a deep carious lesion. Look how close it is to the pulp. It was dressed with a GIC to seal the carious lesion. While we looked at and this other one here was dressed with a GIC as an interim therapeutic restoration. 6 months later, no symptoms at all. So we whole crown this. And this is the image 12 months later. Look at the furcation area. No signs of pathology developing there. There was no symptoms. This one was also treated with an ITR and the whole crown as well. So if you look at the patient, the same patient, 24 months later, the crowns are in situ. There's no focal pathology at all. And that lower right E is asymptomatic. So we combined the ITR with the whole technique. You can combine the SDF, silver diamine fluoride, and produce smart whole or silver modified atraumatic restorative technique, or smart silver modified whole technique. The evidence for that is coming out as we speak. But the whole technique has generated a lot of controversy. And controversy is good. When there's a debate, you know, we're not all yes men or yes women. We debate and there's opposing views. But the opposing views here were almost 180 degrees opposite to each other. In the UK, because it's a UK product, I assume, they said that the whole technique was the golden standard in managing the carious primary molar. While in the US, eminent professors, Prof. Kroll, Killian, and Simonson, said the whole technique was a gross distortion of medicine and science. Who do you believe when you hear that? These are eminent people, respectable, caring pediatric dentists. It created a lot of controversy for sure. In the UK, because it was a UK product, I assume 2 years ago, this fantastic paper published by Amanda Roberts and Sundar Selbedri in the UK and published in the BDJ highlighted that 96% of pediatric dentists in the UK use the whole technique. So, by the way, in 2007, there was great opposition to the whole technique in the UK, but that changed over time. In the US, the trio, Prof. Kroll, Prof. Killian, Prof. Simonson, published article after article questioning the whole technique and saying that it's actually not healing the tooth, it's actually concealing the tooth. So there was an international debate going on here, and they actually wrote to the Pediatric Dentistry Journal highlighting their concerns about this. So our group here in MBRU found an opportunity here to kind of survey specialist pediatric dentists on the global scene. And this was published in the British Dental Journal last January, so it's a year old. And with the help of our colleagues from all around the globe, we actually conducted this survey, and we targeted specialist pediatric dentists. We managed to get about 709 pediatric dentists from all around the world, and the majority of them were working in private practice, and the majority were specialist pediatric dentists compared to consultants. A lot of them were in academia as well. So what did we ask them? Well, we asked them first, have you heard about the whole technique? Out of those 709, the majority said yes. So the message has come through and clear that everyone knows about the whole technique. But was everyone using it? Not the case. There was almost a 50-50 schism here. 50%, slight majority said yes, and just below 50% said no. So it's like a split kind of situation here. This varied from country to country. We couldn't really compare exactly scientifically between country and country because we didn't have the equal numbers. But if I looked at South Korea, the majority didn't use it there for those who knew about the whole technique. While in the US, out of the 118 dentists that were from the US in the survey, 60% said they used it, going at the time against the AAPD guidelines, which didn't endorse the whole technique at the time. It still hasn't, obviously. When we asked those who know about the whole technique, what was their initial opinion when they heard about this technique? Well, it followed a standard bell curve. The majority were in the middle, not sure, while a third were supportive and a third were against, with 6% being strongly against. When we asked them, why did you not plan and use the whole technique? What was your reason behind this? 17% said it was substandard dentistry. And to be honest, this is how I felt when I first heard about the whole technique in the year 2000, in that conference in the BSPD when Dr. Evans stood in front of us and talked about it. And there was 27% said there was insufficient evidence, while others reported other reasons like lack of confidence or lack of payment or insurance approval for the whole technique, because insurance companies have still not caught up with the whole technique being on the scene. The opposing views, we gave room for qualitative comments in this survey, and we had again the complete opposite view. So look at the left-hand side here in the red. One senior academic in the country, again this is an anonymous survey, and said whole crowns are an absolute joke. This is what this person wrote in the survey. If you cannot properly place a stainless steel crown on a child, you either choose the wrong profession or your program, your specialty program, needs to stop handing out certificates. Ouch, big ouch. Others said it was sloppy dentistry. While on the positive side, those who obviously reported positive views about the whole technique, but some said, I would like to try out the whole technique, but my insurance does not pay unless there's a pulpotomy done. So that means we need to negotiate with the insurance companies to see if they would change their policies. Others said, I heard about the whole technique, but would like to use it, but was never taught about it in my residency. Now, for those who used the whole technique, and there were roughly about 358 out of the total, we asked them specific whole technique related questions. We asked them, do you think the whole technique is the gold standard of treatment of choice? Well, only about 70% said yes. Can you see my presentation still? Yes, I think, sorry. Yeah, you can, perfect, thank you. While the 50% or 53% said the whole technique actually is one option out of many. And I think that is the right place for the whole technique. It is one method out of many methods. When we asked them, would you use them in cavitated and non-cavitated class 1 and class 2 molars? The majority said yes, they would use them in class 2 cavitated molars. Now, when we asked them, would you use it under inhalation sedation? And the majority, 56%, said yes, they would. But when we asked them, would you use it under general anesthesia? The majority said no. About 63% said no, they would not use it under general anesthesia, and maybe because of lack of confidence in it. And they would not use it prior to a planned exodontia general anesthesia, which is quite common in the UK. We asked them, actually, would you use high-speed drills prior to the whole technique? And the majority, almost 70%, said yes. In my view, this negates the principle of the whole technique, i.e. not using the drill. But Al-Midani et al. In 2019 published a paper in the IJPD comparing the modified whole technique, as they called it, i.e. mesial and distal slice and fitting the crown without local anesthesia, to the conventional whole crown, which is separators and fitting the whole crown. When we asked those whole crown users and we gave them this scenario, this is still in the survey, we have this carious lower left D in a 6-year-old who's fit and healthy and has no pain, i.e. a non-pulpally involved asymptomatic carious prime molar. How would you restore this tooth? 75%, these are from the whole technique users, 75% would choose a non-whole technique method, whether it's composite, amalgam, or conventional crowns, or zirconia or glass ionomer, while only a quarter said they would use the whole crown. So we concluded in this research that the whole technique is recognized by an outright majority of a sample of patients, of a sample of pediatric dentists across the globe, but only half of those surveyed use it. Barriers such as lack of training, perception as substandard dentistry, and perceived lack of evidence were identified. The use of the conventional restorations remained the preferred option, even amongst the whole technique users. So the jury's still out. The evidence points to about 93% success rate, but that tells you that 7% may fail. That means the whole crown can fail. So Does the whole crown fail? Does the whole fall? Well, the whole does fall, and things can go wrong with the whole crown. This is a Dundee patient of mine who was seen by a general dental practitioner who fitted a crown 2 weeks prior to presentation. The patient presented with a dental abscess. We actually had to extract the tooth. So this is the crown was extracted. Look at it. We thought, what's wrong with this crown? And look, it's fitting fine. What's wrong with it? Then we realized that the carious lesion was not sealed. The crown margins did not cover the carious lesion. The GIC did not cover the carious lesion. So this was an inappropriate use of the whole technique. You have to make sure that your crown covers the carious lesion, and you have to estimate that from the radiograph. If the carious is down to the root level, then the whole crown will not work at all. So it's where the whole crown can fail. Other simple matters with the whole technique can be a simple kind of ectopic eruption, if you like, of a trapped 6 behind an E that's treated with the whole crown. I'm not going to steal the thunder from Dr. AlWaleed, and I'm looking forward to his presentation about ectopic eruptions after this. But we know ectopic eruptions can happen in teeth that don't have crowns on them. So this situation can be simply managed by placing an elastomeric orthodontic separator to distalize a tooth, or use a Holterman appliance, or distalizing the 6 as we standardly do, or even removing the crown, waiting for the eruption, and then placing the crown back on. By the way, this case was was done by my colleague and friend, Dr. Mustafa Abdullah, who is now a specialist in Dubai, and I'd like to thank him for providing these photos last minute. The whole crown, in my experience and many of my colleagues' experience, appeared to cause early exfoliation of the primary teeth, and we were questioning this. Is this happen? Is this happening? And we don't know. Maybe that intrusion of the primary molar caused by the whole crown is inducing or expediting the exfoliation process. Is that happening? Well, I don't, I think it is happening, but I wonder what percentage of them does exfoliate early. But a recent paper published in the British Dental Journal just last year suggests that early exfoliation of the primary teeth treated with the whole technique does not really happen. They looked at 12,000 teeth and found out only 39 patients to fit in this study, but they concluded that there's no early exfoliation. So the whole technique is here to stay. It's one method out of many, according to the Scottish Dental Clinical Effectiveness Programme. Their guidelines are available online, and the latest guidelines were published in 2018. You see the link below there. It highlights that you can restore, you can manage the carious primary tooth using 4 different modalities, all coupled with a prevention program. Complete caries removal, i.e. the drill and fill conventional way, or partial caries removal, like the indirect pulp cap, for instance, under in the drill and fill approach, or no caries removal, sealing in the carious lesion, like with the whole crown or with fissure sealant, or, and this is interesting, no caries removal at all, just opening up the lesion to allow self-cleansing and toothbrushing. And I found out from speaking to a Dutch colleague of mine today that this is prioritized in Holland, and there's a fee given for restorative caries management. They just slice the interproximal area open to allow self-cleansing, and the dentists get paid a fee for that. The whole technique is here to stay, and it can produce beautiful results when used appropriately, like this case that you can see in front of you. Again, conducted by my colleague and friend, Dr. Mustafa Abdullah. A fantastic result with a very happy patient who had 1 tooth extracted under local anesthesia and sedation, and the rest of the teeth were treated using the whole technique. The selection criteria are simple. We have a non-pulpally involved asymptomatic carious primary molar that is not near exfoliation. Rely on a good clinical history and take recent and decent bite wings to decide on the whole technique, and then use your selection criteria. So this is my final slide. I would like to kind of send out the simple message as, don't always drill, fill, and then bill the patient. Seal the tooth, heal the tooth, and let that be the deal. And if you want to bill the patient, you can, then it'll be a reduced cost because the biological approach is much cheaper. I'd like to thank you very much for your attention. I would be very happy to take questions now or later on. and I'm on social media. That's my email there, and that is my Twitter account and my Instagram account. I'd like to thank you again for your attention, and I will stop here.
Thank you, Doctor, for this excellent presentation, and we are appreciated sharing your knowledge with us.
Thank you very much.
Questions? Only questions. If you are plan to make a whole technique in upper and lower D's or E, you are planned to make in one visit or different visit?
Usually, if the patient does not have any symptoms at all, I mean, thanks for this question, by the way, it's a very good question. If I'm not having any symptoms, I would like to make the first visit as a pleasant, kind of funny introduction to the dental clinic, rather than actually exposing the patient to any dental treatment. Sometimes I place one separator in, but I don't tend to do 2 crowns in one visit at the first instance. So on the first visit, it will be kind of hi and hello and introduction and prophylaxis and polishing. Next visit would be placing a separator or 2, and then the third visit would be placing the stainless steel crowns whole technique. And sometimes you can place 2 or 1, but I usually like to start off with 1 wherever possible.
Okay, thank you, Prof. Now we are shifting to next speaker, Dr. AlWaleed AbuShanan. Dr. AlWaleed AbuShanan is a head of division of pediatric dentistry and assistant professor in Department of Preventive Dental Science, chairman of Scientific Research Unit at the College of Dentistry, Ben Sultan University. He obtained a certified advanced clinical training in pediatric dentistry from University of California, Los Angeles. Dr. AbuShanan is completed his clinical training in pediatric dentistry from University of British Columbia, as well as he finished master in craniofacial science. He is fellow in Royal College of Dentistry of Canada in pediatric dentistry. Today will be discussed about ectopic eruption and site-on intervention. Now I would like to welcome Dr. AbuShanan and sharing your screen.
Thank you, Dr. El Patal, for this very kind and nice introduction. Just give me a second here as I share my screen, please.
Okay.
Is it on now?
No, until now, not yet.
Okay.
Below sharing, you have found this error.
I'm sorry?
Below sharing, you found.
Yeah, I'm trying.
Yes, now
okay.
it's running. Yes.
All right, perfect. Sorry about that.
Yes, excellent.
All right, sorry about the delay. I'd like to first thank the Saudi Society of Pediatric Dentistry for their kind invitation, the board members and the chairman, Dr. Aziz Al-Johar and Dr. Manal Al-Malik, for this opportunity. It's my pleasure to be here with you. And I'll try my best to follow up the great presentation by Dr. Hussein. So hopefully it will stand as well as his did. Today I'm just talking about the ectopic eruptions. It's something that is more often than not goes missing and undetected. And unfortunately, it's something that can be prevented easily. However, probably due to lack of awareness and lack of certain skills, it goes unnoticed, which later can evolve into worse problems later on. So what is it? What is ectopic eruptions? It's a developmental disturbance, and it's a developmental disturbance in the eruption pattern of the permanent dentition, and it's most often associated with permanent maxillary canines and first molars and the mandibular lateral incisors. And I want to ask the audience, and they can answer by themselves. How often do you see these cases? And you just brush it off and think that there is no need to do anything. I believe that there is a narrative that goes by that orthodontic treatment can only be done once the child hits puberty or is at the age of 13 or 14 years old, which is unfortunately not true. Sometimes interceptive treatment and phase 1 treatment can be very beneficial. In essence, it can actually prevent phase 2 treatment. And I usually tell my colleagues and residents and students that it's not just a phase, and phase 1 is actually a very important phase that can lead to hopefully no need of a second phase or full braces later on. So I'm going to start by talking about the ectopic first molars. How often do we see them? They are approximately, the literature has told us that 3 to 4% of the population will have ectopic eruptions. It's higher in cleft patients, and siblings will have a higher occurrence of ectopic first molars. So why does it happen? Usually the greater mesial angulation of the permanent first molars play a role into it. The mesiodistal width of the permanent first molars as well. Sometimes a shorter maxilla or a smaller maxilla can affect the eruption of the first permanent molar. Also recently we have had some research that indicates that children who started anti-cancer therapy before the age of 3 will have occurrence of ectopic eruption. And as Dr. Hussein has mentioned earlier, some issues that might arise with the use of Hall crowns is that it might entrap the erupting permanent molar, which is not to blame the Hall crown per se, but just the crowns in general. So I would call it an ill-fitting stainless steel crown. So I always want to say to my residents and students that it's very important whenever you place a stainless steel crown is to avoid this from happening. So you want to ensure that you have an adequate, if you're going for a conventional stainless steel crown and you're prepping that tooth, you want to have a well-fitted crown. You want to ensure that that distal surface is well prepared so that the crown is fitted well. You don't want to have any source of entrapment for the erupting permanent molar, and you want to have, you don't want to have any issues later on. So the goal is to have a well-fitted crown, just similar to this exfoliated crown. I always say that you must make the tooth fit the crown. We more often than not try to fit a crown on a tooth because stainless steel crowns have that forgiveness. But you want to make sure that the tooth actually fits the crown. You want to follow what the crown looks like and shape the tooth to it if you're going for a conventional. The good thing is that commercial crowns nowadays, they are actually pre-crimped, pre-contoured. So they are pretty good at fitting with the natural tooth structure. So Ectopic erupting molars are categorized into different categorizations. We have a reversible ectopic molar, which the ectopically erupting molar frees itself spontaneously, and it frees itself spontaneously from a locked position. And usually it happens or occurs in 2/3 of cases, so around 60 to 69% of the cases. Sometimes we will see some degree of resorption, and then it will erupt naturally into the occlusion. And if the eruptive state reflects early in the development, you just want to observe the ectopic development to determine its prospects. As you can see in this case, there is an ectopic tendency for the maxillary and mandibular permanent first molars, and with just observation, it self-corrected itself within 6 months from that from the initial radiograph. And then we have the other side, which is the irreversible ectopic eruption. It will remain in a locked position, and unfortunately, it would require an active treatment. And we'll go into details later on in regards to which type of treatments that we might need to do. It might lead to an early exfoliation of the primary second molar. You might get some abscess or an infection. The child might be in pain. And the partial eruption of the distal portion of the it will have a partial eruption of the distal portion of the permanent first molar. So the mesial portion would be hidden underneath the gums. So you would get something similar to this. The primary molar is going to give a fight, and it's not going to bulge. And the ectopic molar is just going to dig deep and start to resorb that primary molar. Also, we can also categorize it in terms of severity. We can say that this ectopic eruption is mild in severity, which will happen or occur when we have a limited resorption of the cementum or limited dentin penetration. The resorption of the distal root of the primary molar is also associated with mild conditions. However, it will self-correct later on, and it will not affect the rate of exfoliation. Usually, you don't want to do anything severe here. You just want to observe 3 to 6 months. And sometimes you want to introduce an elastic separator as well. But usually, they will self-correct. And once we go into a moderate ectopic eruption, there will be a resorption of the dentin without pulpal involvement. Also, with moderate cases, you want to observe 3 to 6 months. However, you don't want to prolong your observation, and you want to intervene at that 6 months timeline with an elastic separator or a brass wire. And in severe cases, there will be resorption of the distal root, which will be leading to a pulpal involvement. At the severe cases, children will most often start to feel some sort of discomfort and pain. And that tooth, unfortunately, will be leading to an infection later on if left untreated, along with the other issues that might arise from it. So in such instances, we can treat it with a brass ligature, spring clips, distalizing appliances, which I'm going to get into later. And then you have those very severe ectopic erupting molars. The resorption will reach the mesial root of the primary molar, and unfortunately you would have to extract the primary molar to allow the permanent molar to erupt in a better position. And later on you want to distalize that permanent molar to allow for the 5 to not be blocked and impacted underneath. So what are some of the treatment variables that affect our treatment of choice? So you want to look at the extent of blockage. You want to assess the status of the eruption of the permanent first molar. You want to check the position or the change in position of the permanent first molar. You want to see if there is any mobility in the primary molar. and you want to check the opposing the position of the opposing permanent first molar. So always assess the dental developmental age of the child. If the 6s are already in and 1 6 is still stuck there, that's a red flag for you. And obviously you want to look into the presence of pain or infection. And a lot of research also indicates that when the child is older than 7 years old, there is no room for observation and watching. So you have to intervene to avoid any untoward reactions later on. You want to assess the arch length status, and obviously the cooperation will affect the treatment variables. Which way you go will depend on the cooperation of the child and the parents as well. So if you look here into the 2 panoramic radiographs that I have here, the one at the top was in 2018, and you can tell that this child is heading towards orthodontic treatment. He looks crowded, and there are some red flags for you. And unfortunately, it went unnoticed, and nobody paid attention to the red flags there. And a year and a half later, you can see that the 1 6 and 2 6 started eating away the distal root of the primary molar. And it reached later on to the mesial root as well. So unfortunately, what happened was we had to extract those primary molars, and we had to start the patient with phase 1 treatment to distalize that permanent molar and allow some space for the other issues that are present. So what would happen if we do not treat these cases? As mentioned earlier, we will have an early loss of the primary molar, and we will get a space loss, which is never a good thing. With all of that mentioned, an impaction of the second premolar will be present as well, which is just going to complicate the orthodontic management of this patient. And in some instances, when we have an impacted second premolar because of an early loss of a primary molar, which was due to an ectopic permanent molar, we would eventually have to, unfortunately, extract that second premolar. And possible source of infection, abscesses. So early diagnosis and treatment is really a key to prevention of further root resorption of the primary molars here. So in this case, as you can see, we have a flying premolar, the 1-5. We decided on extracting the 5-5 and place an abandon loop to hopefully allow the premolar to say, hey, we have an empty area here, an empty space. Why not go into it? 6 months after, you can see there's a correction of the eruption path of the 1-5. A year later, you can see that the premolar is already in place and in good occlusion. So moving into the types of management and different treatments methods that we have for ectopic eruptions. The easiest way to correct these cases is with elastic separators or orthodontic elastomeric separators. We usually can use them with mild to moderate cases. And what you need to do is you want to place the separator mesial to the ectopic molar with the head placed on the marginal ridge of the middle of the contact area, and sequentially replace with smaller separators as you go. And you want to leave the separators until the tooth erupts normally, or the separator gets loosened, which will indicate for a need to change into a smaller size. You want to repeat that process until the tooth erupts fully, and then you can remove the separator to allow for a normal eruption. And whenever we're dealing with ectopic eruptions, you always want to overcorrect. Don't be shy to leave your method of management of these ectopic eruptions and overcorrect, always overcorrect. So as you can see here, we have an ectopic 1-6 that's unfortunately stuck underneath a stainless steel crown. So we had multiple choices of treatment modalities that we were thinking of. The first one and the easy one was to observe, nothing happened. and then we wanted to go with an elastic separator. And we had already informed the parents that if this doesn't work, we would have to either go for an extraction of the primary molar or replace the stainless steel crown, as the roots were still pretty lengthy. So we placed the separator in February. At the end of February, you can see that there is some correction of the ectopic molar. And then in March, the ectopic molar was well in place. Another way of managing these ectopic eruptions is using brass ligature. Now, the difference between brass ligature and separators is that in separators, you do not need to use local anesthesia. Brass ligature, sometimes you would have to apply some buccal and palatal local anesthesia to avoid any discomfort that might arise from placing the wire. And you also want to get a radiograph to allow a visualization of the marginal ridge of the permanent first molar and the interproximal contact. You want to prepare the tissue with the chlorhexidine rinse, and as mentioned, you want to provide some local anesthesia. Furthermore, you want to flatten one end of the brass with a Howe plier or cut it at a 45 angle to facilitate the insertion of the brass ligature wire in between the contact area. And then in terms of wire of choice or the size of the wire choice, you can use a 0.028 inch wire. If it's too large, you can go for a smaller size. And sometimes you can actually find these brass ligature in any home depot or home store equipment store. So the wires are tightened and the excess is cut, and then the wire is tucked into the proximal area. You want to take a radiograph to ensure that there was proper placement of the wire, and then you want to see the patient in 7 days or a 3 to 4 week interval for tightening of the brass wire. And after removal, you want to follow up with the patient for 3 months to evaluate the status of the resorption of the primary second molar and how things are going on. As you can see in this case, we went ahead with a brass ligature, and there was some positive correction of the ectopic molar. And then in some instances, you can use a combo. So you can use a separator and you can use a brass ligature. And that's what happened. We used a brass ligature early on and then a separator afterwards. And then you can see that there was 3 months after there was positive occluding first permanent molars. Again, brass ligature first, elastic separator, and then the correction happened there. Now, some of the advantages that we have mentioned earlier was that it's a pretty minimal chair time. You don't need that much time to place these, albeit that the child be cooperative in the chair. It's a direct approach, so you don't have to send anything to the lab. You don't have to take any impressions. There's minimal to no anesthesia. In instance, for the elastic separators, you don't have to provide any anesthesia. For the brass ligature, you would have to give some LA there. And it's relatively easy to perform and inexpensive. And usually there won't be any damage to the permanent tooth and no need for anchorage, which might cause further resorption of the teeth. However, I have to mention that sometimes it has been mentioned that these brass ligature might actually fall off and there's a risk of aspiration, but it hasn't happened with myself or in any of my cases or one of my colleagues' cases. So I think it's pretty safe as long as you know what you're doing in terms of tightening the brass ligature. Now moving onto more of a distalizing appliance, we have the Humphrey appliance. The band is cemented on a primary molar and is soldered and a soldered active spring that extends distally to apply force to the permanent first molar. Because the goal here is to actually push that first molar from that locked position and allow it to go back into its natural position. Also, you can solder an arm on that band so that it's attached on a permanent first molar through enamel bonding occlusally. And as you can see, there's a button placed on the mesial surface of the permanent first molar with an elastic chain to be used as a slingshot of some sort. Another appliance that can be used is the Halterman appliance. So when the primary second molar has not suffered extensive resorption and is symptom-free, we can use the Halterman appliance, and it's pretty widely used amongst pediatric dentists nowadays. The primary second molar is banded with a soldered wire extending distally to the impacted permanent first molar, and then there's a recurved hook on the distal extension. A bonded button is attached to the occlusal surface. Again, it's usually recommended that you place that on the mesial surface, as far mesial as possible. And then a chain elastic is used from the occlusal button to the recurved hook on the distally extending wire to help de-impact that molar. Now, a modification of the Halterman appliance was proposed by one of my mentors, Dr. David Kennedy, who goes by these distalizing appliances. The modification is basically to use a reverse band and loop appliance that extends distally to the impacted permanent first molar. So basically, you can have two spurs on the distal extension, one towards the buccal and one towards the lingual, and then the chain elastic can be placed using a catapult or a slingshot approach to increase the disimpaction force. That's usually placed at 2 to 3 weeks intervals, and it's very imperative that we ask the lab to make the extension of the Halterman appliance sufficiently wide mesodistally to accommodate that full width of the permanent first molar. And as I mentioned, the difference between the modified Halterman appliance is that the modified Halterman appliance gives you some leeway, some room for you to actually control the movement of the ectopic molar. So for instance, if you wanted to push it more buccally, you can do that using your chain elastic. And if you wanted to push it a little bit lingually, you can do that as well. Again, with the modified Halterman appliance, the button should be placed as mesial as possible. This will help us in avoiding any traumatic occlusion if it's placed distally. And sometimes what happens is that we will more often find that the distal portion of the ectopic first molar to be covered with soft tissue, and that can be removed either with laser or a scalpel easily to allow for the exposure of the covered area. And so here, this was a case done by Dr. Kennedy, and as you can see, it's basically a reverse band and loop. The band is covering the primary second molar, and then it goes and extends distally beyond the ectopic first molar, and a button is placed occlusally on the mesial surface, and then an elastic chain that helps push that out of that locked position. And you can see 4 months following that initial phase, the ectopic molar is well positioned. Now moving on from the ectopic first molars, I want to head on to canines. So as we like to say, the canine disobedience. So it's not that common. However, it can range from 1.7 to 4.3 of the population. However, I think it's more than that, because I don't, and I'm sure my colleagues, my pediatric dentist colleagues can attest to that. We see these cases on a day-to-day basis. And unfortunately, it's something that can be prevented easily early on, but it goes missing. and then side effects of not intervening early on occurs and hinders the development or the growth and development of the child. So lots of theories. I'm not going to go into details on the theories of how the canines are ectopically erupting and why does it resorb the lateral incisors. However, simply put, it's usually deep within the maxilla, and it has the longest path of travel to cross. As you can see here in these two canines here, one is in the mandible and one is the maxilla. It's pretty ectopic. It's going and it's almost crossing that midline of the lateral incisor here. So etiological reasons, it could be localized, it could be genetic, and it could be systemic. So tooth size, arch length discrepancy might be a reason. The failure of the primary canines roots to resorb. The prolonged retention or early loss of the primary canines. Sometimes we can encounter cysts or neoplasms. And if we have dilacerated roots, that's not going to help our case with the erupting canine. Also, systemic-wise, if there's endocrine deficiencies, febrile diseases, irradiation, or history of irradiation, that can also play a role into this. Genetic-wise, we know how genetics plays an important role in dentistry, and so heredity, malpose, teeth, and clefts, they all can affect the eruption of the canines. And so, as you can see here, we have a case of canines erupting ectopically, and unfortunately, as you can see, it's pretty blocked by the 1-4, the right maxillary first premolar here. And unfortunately, what happened was that most likely it wasn't managed properly early on. So the canines were not extracted appropriately, and it did not allow for future ease of eruption of the path of eruption of the permanent canines here. So what happens if left untreated? So displacement and loss of vitality of the adjacent incisors, loss of arch length, cysts, ankyloses, pain and infection, resorption of adjacent incisors. And the most severe thing that could happen is that patients will lose their lateral incisors. 20 to 60% of cases will result in severe resorption of the adjacent teeth. 23% of cases will have resorption of the central incisors. 82% will be resorbed in the middle third, and 13% will be resorbed in the apical third. So it might not be a big number, but again, we have to remember that these are the front teeth. So you wanna understand that a simple thing that could be done early on at the child's growth could prevent such untoward movements. So when we talk about clinical signs, you want to assess for delayed eruption of the canine or prolonged retention of the primary canine. If there is an absence of that labial bulge in a 9 or a 10-year-old patient, if a labial bulge is absent in a 9 or 10-year-old patient, eruption disturbance of the permanent canine should be suspected, and a radiograph obtained would confirm that diagnosis. If there is an abnormal inclination and or rotation of the lateral incisor crown, and if there was normal mobility of the primary maxillary canine 6 to 9 months after the lower permanent canine erupts. Now, some of the prognostic indicators, or how can we know if that canine will be in good shape after we intervene? You want to see if that canine position relative to the midline of the lateral incisor. You want to assess its angulation and degree of impaction. Is it labially displaced or is it palatally displaced? And usually the successful eruption decreases as the horizontal angulation increases in ectopic canines. And so Erickson and Kroll, they described a classification of canine ectopic canines, and they divided it into zones or sectors. So we have zone 1, 2 to 3, all the way to 5, and it's usually relative to the midline of the lateral incisors. And it's based on a 2D radiograph, so a zone 1 or a sector 1 would be if the tip of the canine was distal to the root of the lateral incisor, and a zone 2 or a sector 2 where the tip of the canine would be between the distal half of the midline and the midline of root of the lateral incisor. A zone 3 or a sector 3 if the tip of the canine was placed between the midline and the mesial half of the root of the lateral incisor. A zone 4, which we don't want to see, would be if the canine was crossing that midline and jumping all the way to the mesial surface of the root of the lateral incisor. And a sector 5 would be crossing that whole tooth and reaching to the central incisor. And so as a rule of thumb, usually those sectors from 1 to 3 would be a labial impaction, and sector 4 to 5 would be most likely a palatal impaction and would most often cause root resorption. So now that we know how to diagnose impacted canines, what treatment options do we have to manage them? So let's look at this case here. So we have 2 canines that are flying by and reaching that central incisor. So this case for you would be sector 5, and unfortunately, the management of such cases would not be as easy as can be, and usually would require an orthodontic, periodontic, and surgical intervention as a whole team. Another case here, you can see that the canines, the 1-3 here would be in a zone 2, and the 2-3 would be almost in a zone 1 to 2 here. So the management would be straightforward, and we're going to get into it right now. So Erickson and Kroll again, they suggested in 1988 that extracting the primary canines or the early extraction of the primary maxillary canines may result in normal eruption of the ectopically displaced permanent maxillary canine. So they proposed that extracting the primary canine before the patient's age of 11, it would normalize the eruption position of the permanent canine. In 91% of patients that are placed in a better zone, such as 1 and 2 and 3. If the case was borderline 3 to 4 and 5, it would be more or less 64% chance of correcting its eruption. So this procedure usually allows the permanent canines to become upright, and it erupts properly into the dental arch, provided that there is also sufficient space available to accommodate them. So if the patient has already had severe space loss due to premature exfoliation or extraction of D's, E's, or any tooth that is, and there is evident space loss, then this would most likely not work in this case. So let's look at this case here. So this patient presented in 2015, and as you can see, the canines are coming in. They're still up there, but everything's looking good. No issues here, just a normal panoramic radiograph. And then the patient goes missing for a couple of years, and we see that the canines are starting to erupt ectopically. There is some tilting. That 1-3 is in a zone 1, and that 2-3 is almost at a zone 2 to 3 here. So the logical thing would be for the dentist to go ahead and extract those primary canines, because as we read from Erickson Curl, if we extract those canines, we have a 91% chance of those permanent canines to erupt naturally in their correct position. However, it was undetected, no mentions of those ectopic eruptions were bothersome to the in those previous visits. So we go ahead and a new panoramic radiograph was taken in 2020 and no intervention was done again. And as you can see, things are just getting more severe. And if we leave this case for another year or so, it could reach a zone 4 for the 2-3 and a zone 3 for the 1-3 here. So that's why I mentioned that sometimes we as pediatric dentists, we get preoccupied by looking at the caries risk. What are the caries that are present in this child's mouth? And we always neglect the overall growth and development of the child. Always look at the signs that might be setting off some thinking bulbs above your head, and look at things from a whole perspective. You want to take good radiographs, recent and decent, as Dr. Hussein has mentioned, and you want to look at the growth and development of the whole arch. How are the erupting canines coming in? Is the sequence of eruption appropriate for this child or not? And you can build on from that. So again, in this case, the simplest interceptive procedure that can be used to prevent impaction of permanent canines is the timely extraction of primary canines. And I want you to remember that as a pediatric dentist, you do not have to be an orthodontic guru to manage such cases. You do not have to worry about such cases in terms of how are you going to deal with it later on. But the timely extraction of the primary canine can make wonders for these patients, and it will make or break their future treatment later on with the orthodontist. So as we mentioned, there are different management techniques or modalities with the ectopic permanent canines. So we have the extraction of the Cs, 50% and 78% of palatally displaced maxillary canines reverted to a normal eruption path after this procedure. In some instances, we might consider the extraction of the D as well to allow for some room for the canine to come in. In other instances, we want to extract the C and combine it with a cervical headgear. This proved to be of higher success rate in terms of erupting the canine in a good position. And a rapid maxillary expander as well could help in the impacted or the ectopic maxillary canine to erupt successfully into the occlusion. Again, here's a case that clearly requires orthodontic management. However, we were lucky enough to see her early on, along with the appropriate referral to the orthodontist. We decided to extract the primary Cs. As you can see, that 1-3 is almost at a zone 2. And that 2-3 is heading towards that central incisor. And it doesn't really help that the lateral incisors are rotated or having some slight rotation going on. But we did extract the canines, and as you can see, that 1-3 was coming in nicely. And the patient was referred later on to orthodontist who started the treatment for this patient. And in this case, this is another case that we saw that required phase 1 and later on a phase 2 orthodontic management of her for her growth and development. You can see that the canines were coming in ectopically, and we decided that it would be best to extract those primary canines And later on, after replacing a face mask, looking at the premolar area as well and the path of eruption of the canines, I extracted the Ds as well to allow for some room for better occlusion later on. And so I'm going to end with this case as well. This case I started that had no room. As you can see, there is no room for permanent canines to come in. And the patient had already had his premolars in. First molars are well and dandy there. And the central incisor, lateral incisor, and there's no room at all, no space for the permanent canines. And initially, there was a plan to start this kid on an expander. However, due to lack of cooperation of the child, he was a bit of a rebel. So I decided to do a full edgewise appliance here, or braces. And we were able to actually regain that lost space. And as you can see, 2 years on, that canine came in a really, really good spot. And the final picture can show that the occlusion of the child was well. And I want to end with saying that it's very important, you don't have to carry the burden of managing all aspects of dentistry. However, do not bring a knife to a gunfight. And by that, I mean, if you are uncomfortable in managing certain orthodontic malocclusions or such issues, you can do your due diligence and responsibility of providing some sort of an interceptive treatment. That said, it can be as far as an extraction of a primary tooth, or even placing a space maintainer when needed. Or actually just taking a radiograph and noticing those issues that might arise early on, such as the ectopic erupting ectopic erupting permanent molars, or the ectopic eruption of the permanent canines as well. So again, the responsibility of interceptive treatment lies on the shoulders of pediatric dentists. So if you see a canine taking the wrong path with the other clinical signs, extract that primary canine. If you see that a child is 7 years old, all those permanent sixes are in occlusion, and one of them is still stuck underneath primary molar, do not leave it without intervening. Provide some sort of intervention, or refer to that to the dentist that can actually provide such management. So thank you very much for allowing me and giving me the time to present my presentation to you. That's my email. I'm more than happy to answer any questions, and you can find me on social media as well, on Twitter and Instagram. I would like to thank you all again for listening, and hopefully it was enjoyable for you as it was for me.
Thank you, Dr. AlWaleed AbuShanan, for amazing presentation. I will be sure if any questions. Now his only questions for Dr. Hussein.
Well, it is the trendy topic nowadays, right? Whole crowns. So Dr. Hussein, you can take it all you want.
Thank you very much, Dr. AlWaleed, for your fantastic presentation. Very enlightening indeed. I'm very happy to respond to the questions. Would you want me to type the responses, or shall I answer them live?
Yes, questions regarding some children have bruxism at night after placing crown. What's the management?
Well, I mean, bruxism is common in children, and it should subside normally by the age of 3 or 4. And it is noticed whether you place them conventionally, place the stencil crowns conventionally, or using the hole technique. The management particularly would only take place if the child's sleep is being disturbed. And usually the parents report that they're actually noticing kind of the sound of grinding, and it actually can happen even without patients receiving stencil crowns. And I tend to adopt a very kind of conservative approach. If the child is not being disturbed in terms of sleep, then so be it. It will fizzle out eventually. Although I have seen cases of patients wearing having stencil crowns, and these crowns were completely worn through. They actually can see the GIC, and it's a case of replacing those crowns. Now, in severe cases where patients' disturbed sleep has occurred, then it's a case of making a lower soft or an upper soft occlusal onlay for nocturnal wear to stop the grinding, so that could cushion the clenching. But I tend to avoid that in very young patients.
Yes, thank you. Now I'll be on behalf of Saudi Society of Pediatric Dentistry. You have appreciated certificate for Dr. Hussein and Dr. AbuShanan. Now you are seeing in the screen your certificate.
Oh, thank you. Thank you very much.
Thank you, Doctor. Thank you, Dr. AlWaleed.
Thank you very much. There were one or two questions, particularly. I just wanted to answer one, Prof. Mohammed, if I may. Someone asked about the protocol for managing whole technique crowns in patients who have cardiac disease or who are at risk of infective endocarditis. May I answer that question?
Okay, no, okay, if you need
yes.
to ask. Okay.
Yes, the question, it was the whole technique manual does not recommend placement of stainless steel crowns using the whole technique in such patients who are at risk of infective endocarditis. Now, having said that, in the UK, the guidelines for giving antibiotic cover for patients who are at risk of infective endocarditis are different from the AHA guidelines. And there is no evidence suggesting that whole technique crowns can cause bacteremia in patients. But to be honest, I avoid placement of stencil crowns using the whole technique on patients who are at risk of infective endocarditis, and I would manage them with conventional means and carefully not to. If it's subgingival, then it's obviously it needs AB cover and restore as normal. But I would not place stencil crowns using the whole technique. Now, I've seen one or two patients who have had who were at risk of infective endocarditis and were treated with the whole crowns and never developed any problems at all. However, I would not recommend it. I would go along with the whole technique manual, which clearly states that patients who are at risk of infective endocarditis should not be treated using the whole technique.
Okay, another two questions for Dr. Hussein also. Do you advise by topical fluoride application to the carious lesion prior to cementation of crown?
Okay, the conventional method of doing the whole technique does not involve any caries removal. It just involves drying the tooth, cleaning it from any food, and no caries removal at all, and no treatment of the caries. Hence the name biological approach. We're just altering the environment around the biofilm in the lesion that it eventually arrests. However, treating the tooth with fluoride beforehand, or even SDF, so whether it's sodium fluoride varnish or with silver diamine fluoride, is a very valid approach. But the evidence for that is not out yet. It makes sense to use them beforehand. So if you want to do so, now I think there's a study going on in the UK at the moment and looking at SDF prior to placement of the whole technique crowns, and I think we'll just have to wait the results of that study to come out. But it does make logical sense to arrest the lesion before to make sure that you're happy, although we know clinically that the lesion is arrested. Again, there's no sectional studies looking at carious lesions under these crowns histologically, I think there was one study, but I can't recall the author, but I don't think there's a lot of widespread evidence for that. But treating the carious lesion beforehand with a fluoride varnish is a very valid option, yes.
Okay, thanks. And another question, why whole technique is called biological approach?
As I mentioned just in the previous question there, the biological approach means altering the environment, the bacterial environment at the carious lesion by starving the carious lesion from its nutrients, carbohydrates, refined carbohydrates. The carious lesion will arrest, and we know that it will arrest. And it's called biological because we're not involving any medical treatment of the carious lesion. We're just starving it from nutrients and starving it from the contamination in the oral environment. So that's why it was called a biological approach. It involves no drilling, no injections, no excision, no intervention, no surgical intervention from the dentist.
Excellent, Doctor. Thank you, Dr. Hussein, and thank you, dear colleague, Dr. AbuShanan. And see
Dr. El Patal, if I may, I have a few questions here. If you allow me to address here on public.
Okay, I'm not sure.
So I received a few questions here. I'm not sure if it shows on the screen or not, but I was asked what is the best management for an 8-year-old that had lost the 7.4, 7.5, and the 7.3 and has an ectopic 3.6. So obviously here there was an early space loss of the dentition. There was an effect on the arch length status here. So what would be the best management here is to actually place a lower lingual Holden arch. And now, in order for you to actually do or go the extra mile, you can actually activate that lower lingual Holden arch and add the component to distalize the ectopic erupting 3.6. And that's the beauty of the appliances that I have mentioned, the Halterman and the Humphrey and whatnot. And that is that these appliances can be added to any other appliance in conjunction with whatever treatment that you want to do. So if you're going for an expansion, you can add it to the appliance that appliance of choice. And if you're going for a space management, if you're going for a NANS appliance or a transpalator, you can add that component or that arm distal to the ectopic eruption of the permanent molar and use it as a slingshot. And I was also asked what is the age of extraction of the primary canines. So as soon as you see that there is evidence of an ectopic eruption, or if you see that those permanent canines are heading in the wrong path, just go ahead and extract the primary canines. And remember, you never want to extract only one canine and leave the other, because that's just going to create more problems. And I had a question, what is the treatment option if the 5 is missing? Well, that requires its whole other presentation. But in a nutshell, you want to either, you have to plan ahead for the future. So you either want to keep the primary molar sound and intact, or you actually want to extract it and close the space, or you want to actually extract it and hold the space for a later implant. Or you would just have to take care of the primary molar and substitute it, have it as a substitute for the premolar. Thank you, Dr. El Patal.
Thank you all attendees, and see you again next seminar and webinar. Thank you. Bye bye.
Thank you very much. All the best. Assalamu alaikum.
Alaikum assalam.